Good morning again, dear participants. So we are going to start this webinar. My name is Dr. Takishi Nishijima from the WHO Regional Office for the Western Pacific or the WIPLO. I'm a technical officer for AMR, and this is my privilege to welcome you all to this regional webinar, TrACSSing the Path to Action, Reflections on AMR Progress and the Gaps in the Western Pacific. This event officially opens our regional commemoration of World AMR Awareness Week 2025 under the global theme, Act Now, Protect Our Present, Secure Our Future. Today, we are gathered to move from data to dialogue and from dialogue to action. We will look closely at how countries in our region have progressed in implementing AMR responses where challenges persist, and then how we can collectively translate this momentum into measurable change. To open our session, I would like to now invite Dr. Kidon Park, Director of the Division of Program Management, WIPLO, to deliver the opening remarks. Over to you, Dr. Kidon. Thank you.
Thank you, Nish. Distinguished colleagues, partners, and friends across the Western Pacific region. Good morning, magandang umaga. Good afternoon, those who are connected from GMT plus 10, 11, 12 time zones. I welcome you all to today's regional webinar, which is celebrating the World Antimicrobial Resistant Awareness Week 2025. The theme of today's webinar is TrACSSing, the Path to Action, reflections on AMR progress and gaps in the Western Pacific region. TrACSS stands for the Tracking Antimicrobial Country Self-Assessment Survey. The theme of the World Antimicrobial Resistant Awareness Week 2025 is Act Now, Protect Our Present, Secure Our Future. It reminds us that we should act now. Our first course of action should be the implementation of the findings and the recommendation from the Antimicrobial Country Self-Assessment Survey. It is the only way to safeguard lives of the current generation as well as next generation. Almost a century after discovery of the antimicrobials, the world now faces an escalating crisis of the resistance. Globally, 1 in 6 bacterial infections no longer respond to standard antibiotics. And in our region, antimicrobial resistance could cause up to 5.2 million deaths by 2030 if urgent measures are not taken. This is not just a medical concern. It is a threat to health security, sustainable development, and universal health coverage. AMR undermines every aspect of the healthcare, from maternal and surgical care to cancer treatment and infection prevention. Today, we will examine the findings of the 2025 Tracking AMR Country Self-Assessment Survey. We commend the 26 of the 28 countries in the region which submitted their reports, a record high number, which reflects strong commitment across the region. The result reveals encouraging progress in governance, surveillance, and diagnostics capacity. Yet, they also highlight persistent gaps, particularly in financing, workforce capacity, infection prevention, and multi-sectoral collaboration. In parallel, certain member states now contribute data to the global antimicrobial resistant and use surveillance system GLASS, helping to build a clear picture of where the resistance is spreading. WHO continues to support countries to expand participation. because robust data are essential to guide national policies, accountability, and actions. Throughout today's discussion, we will hear from member states and technical experts on how data are being translated into action, from improving antimicrobial use in hospitals to strengthening national governance and accountability mechanisms, as well as embedding AMR within health security and universal health coverage agenda. This discussion comes at a pivotal time. The United Nations General Assembly high-level political declaration on antimicrobial resistance adopted in 2024 commits all countries to reduce deaths from drug-resistant bacterial infection by 10% by 2030. Achieving this goal requires leadership, sustained investment, and measurable results. I trust that today's dialogues will strengthen our resolve to move from commitments to measurable impacts, grounded in evidence, driven by collaboration, and focused on protecting lives. Thank you for your continued partnership and leadership in advancing AMR containment in the Western Pacific region. Together, let us act now, protect our presence, and secure our shared future. Thank you. Salamat po.
Thank you very much, dear Dr. Kidon, for setting the scene for this webinar. So back to the slide, please. Yes. Now, please let me talk about a few quick housekeeping reminders. Number one, please use a Zoom rename function, including your name, affiliation, and then country. Number two, the webinar will be recorded. The recording will be shared afterwards. Please use the QA function to ask questions. And then please introduce yourself in the chat. Also, for any technical issues, please message Wipro Technical Support via the Zoom chat for any assistance. So thank you for your cooperation. Now, to start our session, we will look at the latest result from the 2025 Tracking AMR Country Self-Assessment Survey, or TrACSS, which reflects how countries in our region are progressing in their AMR responses. To share an overview of the key regional trends, progress, and the remaining challenges, I now invite Mr. Juan Paulo Tonorete, Technical Officer for AMR at Wipro. Over to you, JP.
Thank you, Nishi. Good morning and good afternoon, colleagues. It is a pleasure to present the 2025 Tracking AMR Country Self-Assessment Survey, or TrACSS, results for the Western Pacific region as part of our World AMR Awareness Week regional opening event. Before we go into data, let me briefly remind us what is at stake. AMR is expected to cause up to 5.2 million deaths in the Western Pacific region between 2020 and 2030, and if no major action is taken. While globally, nearly 5 million deaths were associated with bacterial AMR in 2019 alone. In 2024, the member states adopted the UNGA High-Level Political Declaration on AMR, which sets important global targets. 10% reduction in deaths from drug-resistant infection by 2030, a full One Health response integrating human, animal, plant, and environment action. 60% of countries to have costed and fully funded national AMR action plans. Stronger surveillance, including AMR and antimicrobial use, using global systems such as GLASS. And importantly, 95% of countries reporting annually to TrACSS. Today's TrACSS results show where the Western Pacific region stands against these commitments. TrACSS is considered one of the most important tools that we have to understand where countries are progressing, where gaps persist, and where support and investment must urgently be directed. This year, 26 out of 28 member states in our region submitted TrACSS responses. This is the highest participation ever recorded at 93%. This level of participation tell us two things. Countries in the region understands the severity of AMR, and countries in the region are committed to tracking their progress and their gaps. This is indeed a strong signal of political commitment, coordination, and willingness to improve accountability. This is a strong foundation for the years ahead. Now let us see what the Western Pacific region is doing well and why it matters. Globally, we are seeing steady progress in the development and updating of national action plans on AMR, and the Western Pacific region reflects this trend. While many countries have now developed their NAPs, not all have been able to secure timely government endorsement, which has delayed implementation. This is evident in the past 2 years, and in addition, financing of NAP implementation, including monitoring, remains limited in many countries. Looking at countries in the Western Pacific region who responded to this year's data call, most countries now have AMR national action plans, with 21 countries implementing the NAPs. This reflects strong political awareness. However, only 6 countries have fully costed, funded, and monitored national action plans. This gap is one of the biggest barriers to sustained AMR action because it leads to a lack of implementation, inability to sustain programs long term, and poor accountability and coordination across different sectors. Stakeholder involvement is crucial for the success of the national action plans on AMR, as it assures a holistic One Health approach, promotes ownership and accountability across sectors, facilitates resource mobilization, and enables effective monitoring and evaluation. However, this year, only 3 countries in the Western Pacific region have all key stakeholders listed, from the professional associations to UN organizations, the academia, the private sector, including civil society organizations and local communities, were involved in the development or in the implementation or in the monitoring of their national action plans for AMR. We all see very encouraging results. 100% of countries indicate that their AMR national action plans is linked to at least one other national plan. This reflects growing recognition that AMR is not an isolated issue. It must be embedded within the wider health and development frameworks. Integrating the National Action Plan on AMR with other national plans is crucial because it ensures coordinated, multi-sectoral One Health approach that addresses the complex drivers of AMR across human health, animal health, and the environment. The holistic integration is essential for effective and sustainable results. As we all know, AMR is a cross-border, multifaceted challenge that cannot be solved by a single sector alone. And seeing all countries integrated their NAP AMR to other national action plans reflects a strong foundation of a whole of government action, and it creates opportunities to leverage resources, align policies, and strengthen accountability. On monitoring and evaluation capacity among countries in the Western Pacific, it still remains very limited. Only 4 countries report adequate monitoring and evaluation systems. And from these 4 countries, only 2 collect AMR-related data disaggregated by sex, geography, or income, or other stratifiers, while another 2 countries, even though they have insufficient monitoring and evaluation capacity, They are starting to collect disaggregated M&E data. Without sufficient M&E capacity, countries are unable to collect reliable data, analyze program effectiveness, and communicate their findings to their decision makers. This severely constrains evidence-based policy adjustments. On multi-sector coordination mechanism, we see countries increasingly recognize that AMR is not just a health issue. However, only 13 countries have a formal multi-sectoral coordination mechanism at present, and just 9 countries, or 35%, include all relevant sectors for human, animal, plant, and environment. This means progress do exist, but coordination may still break down between ministries or sectors, which will then lead to fragmented action. Raising awareness is a cornerstone of AMR mitigation, but nationwide, AMR awareness campaigns remains limited across countries in the region. Since previous years, we can see slow progress in the percentage of countries that implement government-supported nationwide AMR awareness campaigns targeting priority stakeholders with regular monitoring of outcome and impact. On behavior change is slow everywhere in the world, and AMR is no exception. 58% of countries now include evidence-based behavior change strategies, which is a positive step. Countries are beginning to adopt behavior change approaches, not just information campaigns. However, only 8% or 2 countries have trained personnel across all sectors to implement those strategies. And we all know that trained personnel are still limited and are unevenly distributed. So what does this mean in practice? This would mean that patients may still continue to misuse antimicrobials, clinicians may still prescribe unnecessarily, and communities may not recognize AMR as a threat to their families. This gap between awareness and behavior is one of the most difficult to close, but also one of the most powerful. This data shows that countries need more investment in behavioral science, communication, and community engagements, which are key pillars of the World AMR Awareness Week 2025. Now let's move into core technical areas. Monitoring antimicrobial use, or AMU, is essential for antimicrobial stewardship and combating misuse. 60% of countries now collect AMU data, including access, watch, and reserve or aware categories. This is truly a major milestone. However, monitoring use is not enough, and countries in the region must act on data. Countries must ensure 3 things. AMU data are analyzed. Second, AMU data insights are translated to interventions or policies. And lastly, AMU data reporting should be made consistent. On national AMR surveillance system, we are seeing encouraging progress as more countries now have standardized national AMR surveillance systems. And this reflects improvements in laboratory networks, data systems, and national coordination. 13 member states from the Western Pacific region are actively reporting data to GLASS AMR, giving us the clearest picture to date of resistance trends. However, laboratory capacity among countries remains uneven, and data flow from hospital to national reporting needs improvement because oftentimes they are delayed. And integration with AMR and AMU surveillance also remains low in many countries. Still, the progress made in surveillance is one of the region's strongest achievements and reflects years of capacity building. Progress in strengthening IPC systems has also plateaued and even declined in some countries. Few countries have IPC programs implemented nationwide. This is concerning because weak IPC accelerates the spread of resistant infections, especially in hospitals. And outbreaks may be harder to contain and health workers would face higher risks. Therefore, strengthening IPC systems is one of the most urgent areas for renewed investment in countries, recognizing that strengthening IPC is the fastest and the most effective way to reduce AMR in the low middle income countries. Now we move on optimizing antimicrobial use. Here we see also an encouraging movement, as most countries have guidelines and many hospitals are beginning their stewardship programs. However, implementation is still limited to select facilities in many countries. 20 of our countries reported that they have national guidelines for appropriate antimicrobial use, while 13 countries have policies of optimizing antimicrobial use in primary care, particularly for respiratory and urinary infections. The limited implementation are due to AMS teams often lacking time and resources, data for decision making are delayed, and prescribing culture is still difficult to shift. While regions is moving in the right direction, antimicrobial stewardship must extend beyond tertiary hospitals to primary care, where most antibiotics are prescribed. From the region's 2025 TrACSS results, four key conclusions emerge. One, TrACSS remain as a crucial accountability tool. It helps countries identify barriers, mobilize resources, and drive evidence-based decision-making. Second, countries are more committed than ever. High TrACSS participation, strong progress in developing AMR policies, and surveillance systems all show strong momentum. The region is indeed moving in the right direction. Third, financing remains the weakest link. Without costed, funded national action plans, implementation will remain uneven and fragile. Without trained staff and integrated systems, early gains will not last, and policies without resources cannot save lives. Lastly, significant gaps remain in different areas, in nationwide awareness campaigns, in monitoring systems for antimicrobial use, in IPC implementation, and also in the optimization of antibiotic use or antimicrobial use in primary care and in hospitals. These are high impact areas where rapid gains can be made. And to obtain comprehensive country or global TrACSS data, kindly visit the website amrcountryprogress.org. In closing, the Western Pacific region has the knowledge, has the commitment, and the momentum. And the 2025 TrACSS results show us where we stand, and more importantly, where we must go next, where we must accelerate, and where solidarity, financing, and political leadership must be strengthened if we are to meet the UNGA targets, including the commitment to reduce deaths from drug-resistant infections by 10% by 2030. Let us use these insights to guide concrete, measurable improvements across the Western Pacific. Thank you for your kind attention.
Thank you, JP, for the very insightful presentation and for highlighting the both progress and also the areas which need our continued attention. But using this opportunity, I would like to thank the member states again. This year, as JP presented, 26 out of 28 countries in our region has reported to TrACSS, and this is a record high number. This cannot be accomplished without the great support from the member states colleagues. So thank you very much. Now, we are turning into our country experiences. I am pleased to welcome Dr. Ami Ramadanti, Health Policy Analyst and the AMR and the IPC Technical Team Lead, Directorate of Quality of Referral Health Services, Ministry of Health, Indonesia. Dr. Ami will share how the TrACSS findings have informed Indonesia's AMR response and how reforms are aligning with the UN General Assembly political declaration goals. Thank you very much, Dr. Ami, for preparing, this presentation during your very hectic week. But thank you so much. Over to you. Thank you.
Thank you, Dr. Nishi. Good morning, everyone. I'd like to thank WHO WebPro to invite us in this opportunity. So, Indonesia is invited to share our experience in utilize tracking AMR country self-assessment survey. Next slide, please. So the outline of my presentation is three parts. First, the TrACSS itself and area of national action plan that progress significantly. We choose governance. And lastly, reforms to achieve the 2024 UNDA political declaration targets. Next slide, please. So as a background, this is my country, Indonesia. Geographically region, we are quite a large country. We have 38 province, 515 district, and population reach more than 280 million people. And we also have various healthcare facilities, more than 3,000 hospitals, and more than 10,000 public healthcare and more than 20,000 private healthcare. Next slide, please. Next slide, please. Okay, excuse me, can you read it? So regarding the TrACSS, since 2017, Indonesia has actively participated in this TrACSS survey. And the TrACSS survey clearly helped us in providing the information in National Action Plan implementation. So in the last 2 years, when I joined the AMR team, we usually, when it's time for TrACSS self-assessment survey, we will convene all the stakeholders, and we will sit together and we'll discuss the item and the parameter in the TrACSS survey. And at that moment, we get the opportunity to discuss challenges in National Action Plan implementation. Also, TrACSS result provides information on country progress over the years. And lastly, TrACSS reports points out the issue that needs attention. So for the last point that helped us, for example, this year we start to involve private sector because during the TrACSS survey in 2024, we found that private sector not actively engaged within our AMR program. So TrACSS reports points out one issue that needs attention. Next slide, please. Next. So in the last 3 years, we see the progress in the strengthening governance for AMR program. In 2023, we only have National Action Plan, National Committee, National Working Group. We assign National Laboratory Reference Lab. We also have AMR Task Force and some regulation. But since 2024, we have a national strategy on AMR specifically for human health, 2025 to 2029. So also, we decide that AMR become the mandatory program in our accreditation standard for hospital. It means that all the hospital in Indonesia is mandatory to implement the AMR program fully implementations. Also in 2024, in addition to our previous collaboration with Fleming Fund and WHO, we also have another collaboration with Dutch government. We have the IMS antimicrobial stewardship workshop in 2024. So in 2025, the AMR program indicators is embedded in our national midterm development plan. So for this year, the commitment of Indonesia government is more clear, and it means that the government must allocate budget and resources to support the achievement of this target. Then AMR IPC technical team formed in the Ministry of Health. Before we don't have specific team for AMR and IPC, but this year we already have specific team assigned to do all the AMR and IPC work in the Ministry of Health. Also, we develop more regulation this year, regulation regarding the technical guidelines, more technicality for the hospital to implement the AMR program. And also this year we we nurture more partnership and collaboration with the district health office, provincial health office, private sector, the National Institute of Infectious Disease, Japan. Also, we have collaboration with Sweden, Indonesia Sustainability Partnership, and REACT. And also, we develop a community of practice. Next. Next slide, please. So this is the National Action Plan on AMR we have. Next. Next slide. And in the left side is all the regulation we develop, and the last 6 is the new regulation we develop. And on the right side is our National Development Plan, and it shows 2 indicators that related to AMR. Next slide, please. And key challenges is first, many stakeholders involved in the AMR programs. It caused difficulty in coordination, and the program become more silo and fragmented. And also national collaboration need more effort because we have 38 province and more than 500 district and a large number of health facilities. Next slide, please. So for UN geopolitical declaration target, next. Yeah, so we did the mapping for all hospital, Ministry of Health hospital and provincial public health hospital to evaluate their capacity to conduct the antimicrobial test, the resistant test. And we can see also 20 public health laboratories support all the hospital. We only have 29 Ministry of Health hospital and 53 public health hospital that have the capacity. Next. This is what we did. We do the map, and this is the capacity of the laboratory and the number of the laboratory for each tier. Next slide, please. And we report glass IMC surveillance to glass, and it's shown that for antibiotic use, the access category is already reached more than 70%, but we still working on to maintain and improve this achievement. Next slide, please. And also we built 2 information system for AJIS surveillance and AMR program to the national level. This 2 system is now we still improve the system to support the reporting. Next slide, please. So national reform to support the achievement of political declaration target. Firstly, we strengthen AMR's regulation. Still, we're ongoing development some of the guideline and regulation. Also, we include AMR within the broader strategy. We strengthen the surveillance, and we nurture collaboration and partnership with others. So this year, we also include private sector in our activity and program. And for AMR strategy, one of our main strategy is we include the AMR within our accreditation system. And accreditation is one of the strongest, the robust and the strongest intervention are now in Indonesia, mainly for hospitals. So when we put the AMR within the accreditation program, all hospital must implement the AMR program and must achieve like 100% of the implementations. Implementation includes the antibiotic evaluation, include the surveillance, includes as well all the training that needed by the staff in the hospital that must be fulfilled by the hospitals. I think this is my last slide. Thank you very much for your attention. Over to Nishi.
Thank you very much, Dr. Ami. to share your very insightful, activities and achievements for the Indonesia. And then again, we are pleased to welcome you and Indonesia to WAAW from, this May. And we are very, very pleased to have the opportunity to visit Indonesia in August to work with your team to, work on the AMR. Yeah, you have introduced so many achievements, but you didn't mention about this, your national action plan, which is the first one in the world to incorporate people-centered approach on AMR. But I would just like to say that. So thank you again, Dr. Ami. Next, now we would like to welcome Miss Nancy Bala from Papua New Guinea. Miss Nancy Bala is a licensed pharmacist, a Fleming Policy Fellow, and currently serving as a licensing and registration officer at the Pharmaceutical Services Standard Branch of the Department of Health, Papua New Guinea. She leads and contributes to Papua New Guinea's national AMR and also AMU activities. So thank you very much, Miss Nancy. Over to you.
Good morning, good afternoon. And thank you, Nishi, for the introduction. And thank you, WHO, for this opportunity to present on the Papua New Guinea TrACSS experience. I'm Nancy, and I will be presenting on behalf of Papua New Guinea. Next slide, please. So to begin with, I would like to give a background of Papua New Guinea or the country context. So Papua New Guinea has a population of over 10 million people, and it is the most linguistically diverse nation in the world with 800 plus spoken languages. Geographically, it is mountainous. It has mountainous, rugged terrains. It is made up of islands, lowlands, and the coastal. Next slide. In terms of the TrACSSing AMR country self-survey, PNG first participated since 2022. And in terms of how TrACSS is normally conducted in the country, previously, the previous approach was that TrACSS was completed by the different sectors at different times, and then it was submitted. But currently, since 2024 and 2025, all sectors, human health, animal health, and environment, we all collaborate and complete the survey in one place, thus improving timely reporting and strengthening cross-sector verification. And the key areas that are assessed are governance, surveillance, antimicrobial use, and awareness. Next slide. In terms of the areas of the National Action Plan that have advanced significantly, firstly, in terms of the National Surveillance System for AMR in humans, this indicator has been improving over the last 5 years. And the status, in terms of the status, there are currently 5 surveillance sites established in the regional hub hospitals. Secondly, in terms of adoption of the AWARE classification, this indicator is also improving, and we have around 70% of antibiotics in the medical and dental catalog, which is our country's essential medicines list. And these are from the access group of our classification. In terms of capacity to conduct antimicrobial sensitivity testing, this indicator is also improving, and ASTs conducted in the 5 surveillance sites. In terms of IPC, infection prevention control, this indicator has also improved, and currently there is the national IPC program, and we have a IPC policy, and the IPC guideline was recently launched. And in addition to that, I would like to say that 23% of the facilities are WASH facilities. Finally, for the multi-sector coordination mechanism, this indicator has also improved, where we have human, animal, and environmental sectors have focal points who drive the AMR coordination work in each sector. Next slide. In terms of the key challenges that we face with the AMR work in our country, firstly, I would like to highlight the sustainable financing, which is a major gap, which is a major challenge in the country with funding gaps. So at the moment, AMR is not budgeted in the national budget, and currently funding is through donor funding, and we have sustainability issues. In terms of human resource constraints, which is another challenge, the AMR Secretariat and sectoral focal points are not full-time AMR personnel. So the AMR work is additional to their job descriptions, which results in competing priorities that occur, and sometimes AMR work is hindered. The third challenge that we face in the country is on data collection and data quality issues. We have data collection and data quality issues. Fourthly, in terms of reduction of deaths associated with bacterial AMR, currently in the country, there are gaps in having baseline data that exist. So this makes it hard to determine this. I put in terms of the sustainable financing of the NEP, implementation of the NEP on AMR does not have a national budget. And in the second NEP, implementation activities are targeted to the programs, existing programs that we have. So where funding can be accessed via those specific funds. However, this remains a big challenge in implementation of the National Action Plan. Next slide. Next slide, please. Oh, yeah, sorry. So the current status and actions to achieve the AMR targets, according to the ANGA political declaration, AMR currently, in terms of AMR baseline data available in the country, currently PNG does not have baseline AMR data available, and this is a recognized challenge. And the country has recognized that, and steps are being taken to address it through surveillance strengthening and data collection initiatives. Next slide. So in terms of the national level reforms or the PNG's approach to achieve that, firstly, we are doing the updating of the NEP for AMR. That is the second NEP for our country. That's from 2024 to 2028. Secondly, embedding AMR in broader health strategies, such as universal health coverage, primary health care, pandemic preparedness, and climate resilience. Thirdly, strengthen governance and One Health coordination across human, animal, and environmental sectors. Fourthly, to continue to implement WHO AWARE classification in the medical and dental catalog, which is our essential medicines list, and the National Antimicrobial Guideline, which was the first one ever developed in the country, and that was launched at the end of last year. Fifth, we want to ensure supply chains are strengthened, including for antimicrobials and diagnostics for better forecasting and logistics. 6, currently in the country, there is a high-level political support, meaning our high management are aware of the AMR issue. However, and they are engaged in the work of AMR, but there is a need for sustainable financing. And finally, to leverage donor partnerships to address the funding gaps, thus implementation can be accelerated. And I want to go back up to that, the second last comment when I was talking about in terms of high-level engagement and in terms of sustainable financing. Although we don't have the sustainable financing, but we are at the moment in terms of implementing the second NAP, we are riding on existing programs such as IPC to access those specific funds to carry out the AMR activities. Next slide. So in terms of priority areas and next steps, firstly, we want to strengthen the surveillance and lab capacity and awareness. And secondly, to finalize and implement second NAP on AMR. When I say that, to give an update on the current second NAP, it's already been finalized, and we are looking forward towards endorsement and the launching. And thirdly, continue with the TrACSS engagement and regional collaboration. Thank you very much. That's the end of my presentation. And I would like to acknowledge, next final slide. Thank you. And in conclusion, I would like to acknowledge all our partners in the country in the AMR work. Thank you very much.
Thank you very much, dear Ms. Nancy, for your very insightful presentations. I think you have shown, many progresses Papua New Guinea has made, including like a national antibiotic guidelines dissemination, and then also Papua New Guinea has joined the GLASS AMR to start the AMR surveillance data globally, and then the number of the hospitals reporting such data has been increasing. So congratulations for those achievements. And thank you so much for also mentioning the issue about the sustainable financing or funding. Not only Papua New Guinea, as JP highlighted in his presentation, it's a global issue. And I think we are going to have some comments around the sustainable financing in the following section by an expert as well. So thank you very much, Nancy, for the excellent presentation. Thank you.
Thank you.
Thank you. So for the participants, in this webinar, there is a Q&A function, and there will be a Q&A session later in the webinar. So please feel free to write up any reflections and also the QA in the Q&A tab, which you can see at the bottom of the webinar, the Zoom. And then that will be addressed by either the experts or the WHO colleagues. Thank you very much. Now we will move to the expert reflection segment, and to lead this part of the session, it's my pleasure to introduce Dr. Geraldine Hill, our coordinator for the Essential Medicines and the Health Technologies Unit under the Division of Health Systems and Services at Wipro. So Geraldine, over to you, please.
Thank you very much, Nishi. And thank you to all our country speakers for your excellent and very informative presentations. What we've just heard clearly illustrates that there is progress against antimicrobial resistance across the region, but also that challenges remain. Translating AMR policy into practice requires not only strong national leadership, but also practical support, resources, and collaboration at every level. In this next segment, we'll hear from our expert panel, who will help us reflect on the key findings from the 2025 TrACSS and the country experiences that have just been shared. Our discussion will focus on what's working, where are the persistent gaps, and most importantly, how we can accelerate progress together. I'm very pleased to be joined today by 3 experts in the region, who will each share their insights on strengthening stewardship, governance, sustainable financing, and mainstreaming AMR in health service delivery. Each expert will have 2 minutes to share their remarks. After hearing from our panelists, we'll open the floor for discussion and questions from participants. So please do continue posting your thoughts and questions in the Q&A box. So it's my pleasure to introduce our invited experts. First, we have Dr. Arthur Desi Rahman. Dr. Rahman is an infectious diseases specialist with strong expertise in IPC, antimicrobial stewardship, and MDR pathogen surveillance, contributing to national and regional training outbreak investigations and multi-center research. He is a key contributor to the Philippines AMS training modules for healthcare facilities. Next, we have Associate Professor Un-Tek Nang. Associate Professor Un-Tek Nang is a senior consultant, Department of Infectious Diseases, National Center for Infectious Disease, or NCID, Singapore. He heads the Infectious Diseases Research Laboratory and is the chair of the NCID Quality and Safety Unit. In addition, he is the director, AMR Coordinating Office, Communicable Diseases Agency, and is an associate professor at the Lee Kong Chian School of Medicine, Nanyang Technical University. Professor Un-Tek brings expertise in integrating public health, laboratory medicine, and clinical practice to strengthen systems and improve patient outcomes. And last but not least, my colleague, Dr. Annie Chu. Dr. Annie Chu is coordinator of the Health Policy and Service Design Division under the Health Systems and Services Division at WHO WIPRO. Annie's work is centered on health policies and reforms for moving towards universal health coverage in the Western Pacific region. So, to start us off, I'd like to invite Dr. Desi Rahman to share his reflections. Over to you, Dr. Rahman.
Good day, dear colleagues. The TrACSS 2025 data presents both encouraging progress and critical gaps for all countries involved, and this demand immediate action. In alignment with the UNGA 2024 commitment to reduce AMR-related deaths by 10% by 2030 and ensure antimicrobial stewardship becoming a core patient safety function rather than an optional program, it is very important that we address these concerns. The Philippine data reveals sort of a paradoxical situation that also requires urgent intervention. For example, the Philippines has achieved level E for monitoring facility-level antimicrobial use with data regularly collected, publicly reported, and used for specific interventions. This represents an infrastructure for surveillance. However, our IPC implementation remains at level C with guidelines available on selected facilities implementing them with monitoring. This disconnect between monitoring and implementation represents one of our critical barriers to changing how our clinicians prescribe antibiotics. From my perspective as a clinician, both in public and private sector, with some visibility in public health, at least 3 factors can enable successful AMS implementation. Number 1 is integration with the existing quality improvement system rather than creating parallel structures. This can be patterned from or anchored to existing QI programs. In the Philippines, for example, we are trying to develop a system initially anchored through selected HIV treatment hubs, and then we plan to extend it to the AMS committees and infection prevention and control committees. The antimicrobial stewards and the IPC champions are, ourselves experts in QI and internal or external audits and or accreditation. Number two, realize that there is really a spectrum of skills, technical capabilities, resources among various types of healthcare facilities across countries, the Philippines included. To ensure that the AMS fire is burning, it is best to identify and train local champions and create networks linking the tertiary cares, the tertiary hospitals with a lot of capabilities with the local hospitals, the primary care facilities, the district hospitals, and other types of healthcare facilities. And number three, we want the availability of simplified, context-appropriate guidelines that acknowledges the resource limitations across different levels of care. Research and data are very important to generate evidence-based clinical recommendations. In the Philippines, for example, our point prevalence surveillance data on antimicrobial use showed lack of compliance to surgical antimicrobial prophylaxis. And so, by the end of this year, we intend to come up with our first intervention to address this specific problem. And this is to develop or come up with a unified surgical antimicrobial prophylaxis guidelines for clinicians. So the primary barriers remain, in the Philippines at least, maybe in other countries as well, inadequate laboratory capacity for culture-directed therapy, and the persistent perception of antimicrobial stewardship as an add-on program rather than an essential patient care. To align with UNGA's vision of antimicrobial stewardship as a fundamental to healthcare quality and safety, then we should incorporate the following safety mechanisms, but this is a list not limited to just this. Number one, coming up with a surgical safety checklist to include yung antibiotic timeouts, expansion on surveillance to include healthcare-associated infections, and this is something that we want to initiate by this year or first part of next year in the Philippines. Incorporate infection prevention and control bundles of care appropriate per hospital area, conduct mortality and morbidity reviews, and look at our accreditation standards. We want to link hospital licensing to mandatory AMS program indicators, not necessarily to restrict their operations because of non-compliance, but to ensure that measures are in place so that AMS and IPC programs are institutionalized in every healthcare facility and that all standards are implemented. And finally, the TrACSS data shows we have the surveillance foundation. With the UNGA target of 90% of countries meeting WHO minimum IPC requirements by 2030, we must now translate monitoring into systematic and practical practice changes. We can start one at a time and expand as we gain more buy-in in our own healthcare facilities, in our own institution. We should encourage that every antibiotic prescription is a patient safety decision and not just an infectious disease concern, and that antimicrobials are a shared resource. Thank you very much.
Thank you very much, Dr. Raman. Next, we have Professor Untitled to share your reflections, please. Thank you.
Thank you very much, Dr. Geraldine. Can you hear me?
Yes, we can. Thank you.
Oh, thank you very much. So from Singapore, we would like to firstly express our appreciation to Wipro for organizing this webinar to facilitate best practice sharing among member states and experts, and also providing us an opportunity to share about lessons learned from the work in Singapore. For context, since 2016, Singapore has participated in TrACSS. TrACSS has played an important function as a survey measuring largely process indicators, which are aligned with global and national AMR targets. Singapore's approach to AMR control has emphasized effective multi-sectoral One Health coordination, and this has been a central principle in the Singapore's first AMR National Strategic Action Plan, or NSAP for short. This is further strengthened in our current second NSAP, which was just launched this month. The Singapore One Health AMR Work Group, which meets regularly, coordinates AMR strategies, and is comprised of representatives from all relevant One Health sectors. This is very much aligned with the One Health approach advocated and measured by the TrACSS survey. TrACSS, which adopts a systematic approach to evaluate process measures, complements our national level indicator monitoring, which measure the efforts to combat AMR. Regular assessment and reporting to TrACSS will facilitate assessment of the progress of AMR measures over time at national level. And we are happy to report that in recent years, we have made progress, especially in the adoption of AWARE classification for antibiotics, and also strengthened provisions for aquatic animal health services. Additionally, in our experience, TrACSS has provided a common language, so to speak, to facilitate sharing of best practices and progress in discussion with fellow member states and experts. And as member states share progress and challenges, referencing common indicators, there's a readily available, well-organized framework for learning for us, as well as hopefully our colleagues. We are heartened that TrACSS emphasizes integration of AMR efforts into sustainable healthcare frameworks. AMR efforts in Singapore have always adopted a similar approach, even prior to our participation in TrACSS. And from our experience, the importance of embedding AMR efforts in sustainable healthcare frameworks has always been apparent and has been validated by what has happened. So with that, I thank our colleagues at Wipro for this opportunity to share our experience and reflections.
Thank you very much, Dr. Untek. So I will now like to pass the floor to Dr. Annie Chu to share reflections from her side. Thank you.
Thanks very much, Geraldine, and thank you so much for having me for this webinar. Just very quickly before some of my reflections is that I appreciate the regional as well as the country experiences and presentations. It really goes to show how TrACSS has also triggered better coordination and that opportunity to also work across the multiple sectors in assessing the progress as well as ongoing challenges, as we've seen in Indonesia and Papua New Guinea. So that's really excellent to see and hear and learn from. A few comments from my side as well in terms of, number one, underscoring the importance of the legal and regulatory frameworks for AMR, as well as their integration into the broader national health and development plans. And as a part of this, really the implementation, both, of course, at national level across the sectors, but also across the sectors at sub-national level as well, especially in several countries in our region where sub-national level work is critical. And countries have also mentioned about the importance of sustainable financing and that there is still much progress left in this space. Really, it's also about changing the mindset in that this is an investment in the future to prevent deaths and morbidity and also lost productivity from AMR. And so really the investment in AMR prevention, surveillance systems, and response is critical for this. And then in terms of the implementation of the frameworks, a lot of the policies and plans also touch on really how to incentivize and change people's behavior, both from the provider side as well as from the patient side as well. The second point is that clearly we've seen in the TrACSS survey results that there is still a need to better integrate IPC programs in the quality and safety frameworks for patients and for health workers protection. And certainly IPC is fundamental to preventing the infections and further spread of the infections and protecting people, both patients and health workers. And as mentioned earlier, that it really is not just effective, but cost effective, most cost effective measure for preventing AMR. And that this should also be seen, as we've heard from Dr. Desi as well, in terms of complementarity with the AMS programs in health facilities. And my third point is on access to essential health services and essential medicines, including antimicrobials, and how this is really an important and critical part of universal health coverage in countries' advancement in their journey towards universal health coverage. This means equitable access, especially for the most vulnerable, and reducing financial hardship in terms of accessing essential antimicrobials. So thank you very much again, and look forward to the discussion.
Thank you very much to all of our experts. So Dr. Desi, who talked about the ensuring that stewardship becomes a core patient safety function, not just an optional program, and to Dr. Ontek for talking about how governments can leverage TrACSS results to guide national policies and accountability frameworks and sustained financing, and to Annie for reflecting on how countries can mainstream AMR indicators and stewardship and IPC within broader health quality and safety and accreditation frameworks. So thank you to our experts for your thoughtful reflections, and which give us some practical pathways forward. So we'll now move to our Q&A session. To get things started, I'd like to begin with a few questions that have emerged from the themes that we've heard today. But please do continue to add your questions to the Q&A and comments to the Q&A box in the Zoom link. So first of all, I'd like to ask Dr. Desi Rahman, how can antimicrobial stewardship be reframed not as a standalone initiative, but as a core patient safety function that every clinician owns?
Yes, doctor. You know, when we started implementing and started rolling out the AMS program across healthcare facilities, most of the teams would actually say, this is another program to comply with. But you know, we really have to develop with them a change in the mindset that AMS is really for patient safety. And so having said that, we should try to reach out to low-hanging fruits within institutions that we can start our AMS strategies from. But before we even do that, when we start implementing, we have to ensure that we get the buy-in of all of the stakeholders, because if we don't get their buy-in in the first place, then we really would have a hard time implementing these strategies. So at the outset, when we generate or when we form our AMS teams, we should ensure that the heads of the clinical departments are well represented, and make sure that their inputs are heard before we even start implementing. But to answer your question, how do we make it not an additional work? We should make it institutionalized. For example, what I mentioned in my presentation is coming up with a surgery safety checklist to be implemented across all surgery patients. We would also like to ensure that infection prevention and bundles of care are implemented that is specific to each of the healthcare facilities. No, each of the areas within the facilities. For example, for ICUs where there is a lot of intubated patients, then it is best that we come up and make sure that upon admission, we already implement the standard bundles of care for VAP or HAP prevention and all those. Over.
Thank you, Dr. Rahman. And I also liked what you said in your presentation, just your reflections before about every prescription being a patient safety intervention. So thank you. Following on from that, I'd like to ask Dr. Untek, given the TrACSS findings, what are the immediate priorities the ministry should fund within the next fiscal year to align with the UNGA 10% mortality reduction target? And how should those priorities be costed into the national budget? Thank you.
Thanks a lot, Dr. Geraldine, for that question. I guess at a broad level, my first response would be it's very contingent on the national context. So I think in many of these cases for the plans and the costings, there's always this caveat that says that you need local data and you need to contextualize it to what is happening in the region as well as in the country itself. So what would be relevant in Singapore, I think, would be very different from what's relevant in, let's say, Papua New Guinea or Japan or other countries. I can speak, I guess, at two levels. I think at a broad level, in the global experience, what I'm seeing is that there are moves to model the estimates broadly. So, for example, the IHME has estimated AMR-related mortality, and then there'll be global programs to try to catalyze action plans, try to learn from each other and collaborate at a broad level to do this. And really, we are very happy to participate in meetings such as this with Wipro and other international organizations exactly for this reason. I think much can be done at regional and international level to advocate as well as to learn from one another. At a country level, I think one of the challenges is actually to estimate AMR associated or attributable mortality, which can be somewhat technically challenging or an area that needs some technical expertise. So the epidemiology and analysis needed to analyze is actually not so straightforward. We are glad to report that in Singapore, we have started the process and we should be gathering data in 2026 to enable us to do this. A related point is that we are aware that WHO has a guidance on how to estimate country level mortality, and we were happy to share that in the latest or the previous on-site Wipro meeting that we have adapted their protocols to the Singapore context. So if any other member states are interested to have discussions on how we did this, we'll be more than happy to share that experience. And I guess as for prioritizing resources, our approach in Singapore has generally been to identify the efforts that have most impact and to prioritize resourcing there because, as we all know, healthcare financing is always a balance, a trade-off. There's very few situations in healthcare financing where anyone would say there's more resources than there are needs. So that's always a tricky area. But generally, our approach is to go where the biggest bang for the buck is. I hope that addresses those questions, and yeah, we'll be happy to discuss further if needed. Thank you.
Thank you very much. That's very good advice. We have some questions in the Q&A box. Could I just quickly, before we move to that, just ask one question to Dr. Annie Chu about how can AMR be mainstreamed into routine health system strengthening? So interventions are sustainable rather than project-based in light of UHC and the UNGA political declaration.
Thanks. Thanks very much for that question. I think that as we have heard also from the experts' reflections as well as the country experiences, that there are different entry points in terms of integrating AMR into health system strengthening. For example, looking at the health facility level, looking at IPC, strengthening IPC IMS programs at health facility across the various levels, including primary care facilities as well. There's also some of the experiences in incorporating some of the key indicators that we have heard related to IPC and AMR in accreditation or plans for licensing requirements. Those are also areas that would help with that regard in terms of health system strengthening. And I think just very quickly that as mentioned before, that the equitable access to affordable antimicrobials is certainly a foundation for universal health coverage, and that the aspects of looking at in terms of the whole supply of medicine, as well as the affordability of medicines, especially to most vulnerable populations, is of course another area that's really important in terms of health system strengthening and broader UHC and health security. Thanks.
Thank you, Annie. JP, would you like to read out the questions from the Q&A?
Thank you, Dr. Geraldine. So we have received several questions in our Q&A box. And maybe I can read one question and maybe request our concerned expert to answer the question. So first, a question for Dr. Desi Roman. One of our participants is very curious about the surgical antibiotic prophylaxis. And it would be great if you can reflect about the success and barriers that you have encountered during the PPS SAP.
Yeah, thank you. We have been trying to implement our annual antimicrobial use point prevalence survey across different healthcare facilities in the Philippines. And in that point prevalence survey, there are several quality indicators for surgical prophylaxis. And we found out that as of the 2024 data, I'm looking at it, 85% of the antimicrobial surgical prescriptions were given for more than 24 hours. And you know that for surgical antimicrobial prophylaxis, it should be given just one dose or at most in 24 hours and then discontinued. So because of this, we consider this a low-hanging fruit and a very important area for intervention. So for this year, we are developing an antimicrobial surgical prophylaxis guidelines. We invited all of the heads and representatives from the different surgical societies in the Philippines, and we are coming up with at least 10 questions listing down the different surgical procedures and the corresponding antimicrobial recommendations. We have also tried to come up with an evidence review showing them and convincing them that in fact, prolonged use of antibiotics post-surgery is not needed, it's not warranted based on the evidence. And so really we would want them to comply with the 24-hour surgical antimicrobial prophylaxis duration. So we intend to come up with the guidelines hopefully by the end of this year, and we'll be able to disseminate it with the rest of the clinicians first part of next year.
Thank you, Dr. Desi. We have another question. We know that some country report indicates that dentists prescribes about 10% of antibiotics globally, and inappropriate prescribing rates by dentists can reach up to 80% in some cases. One of our participants would like to ask if there are ongoing works in the countries to strengthen stewardship, such as training, surveillance, or monitoring, together with the oral health teams. Professor Ute, you might want to answer or take this question.
Thanks a lot, JP. Yeah, I'm heartened to share that from Singapore. I think our dental colleagues actually are the ones who realize the importance of this issue, as the participant has raised up. And the dental professional group actually has established dental guidance for antimicrobial or antibiotic use surrounding dental procedures. I believe that it is available online, and essentially a clinical practice guidance. It's relatively comprehensive. To my recall, it's about 100 pages when I looked at it. And in Singapore, I found this very helpful because it will establish a common practice, reduce wasteful variation. For those who are in quality work, you would know that that's very common in healthcare. And often the reduction in variation to best establish evidence-based practices will help to ensure appropriateness and quality of care. So that's the approach I've taken in Singapore. Monitoring of this use is monitored as part of the overall antibiotic use that we collect, which also does integrate the AWARE classification. So if anyone would like to find out from us or get access to our guidance, you can feel free to contact us. We're happy to discuss or help. Thank you very much.
Thank you, Professor Untek, for the excellent response. Allow me to relay additional questions, Dr. Geraldine. This is a question from one of our participants who would like to hear more on how sustainable funding for AMR can be achieved based on any of our experts' experience or learning from other programs. It can be from AMS, IPC, and others. Perhaps Dr. Desi, would you like to take on the question? Or maybe Dr. Anichu as well?
So based from my experience, really it will take a high-level decision to ensure that funding for AMR and IPC are ensured. So from our end as clinicians and healthcare workers, it's very important for us to ensure that our lawmakers, for example, and our high-level decision makers are actually aware of the problem and consequences of antimicrobial resistance. So it's up to us to advocate for these problems. So in the Philippines, for example, as far back as 2014, we were able to come up with our plans, and even earlier than that, we can leverage on emerging infectious diseases to help us in our cause, di ba? When people are aware of emerging infectious diseases and antimicrobial resistance, then we can use that our experience from COVID-19 moving forward. So in the funding of our antimicrobial resistance surveillance, we have our antimicrobial resistance surveillance of the Philippines, and every year this is already being funded and part of the our Ministry of Health's funding. And just recently, we are also receiving an annual funding for the conduct of antimicrobial use and point prevalence survey. So we want to start with those two, and as I mentioned in my presentation earlier, something that I would like to institutionalize as well and begin and make sure that funding is consistently given is on the surveillance of healthcare associated infections. Over.
Thank you very much for the discussion there and for your very informative answers. Unfortunately, in the interest of time, I think we're going to have to wrap up the Q&A now. So thank you for such an engaging exchange. Progress is uneven. The region is moving forward together, learning from one another and building a stronger, united front against AMR. These insights will feed directly into our regional follow-up and the next TrACSS cycle. Today's exchange has reminded us that behind every TrACSS data point is a real story of health workers striving to use antibiotics wisely, of laboratories building diagnostic capacity, and of policymakers translating evidence into national action. We've heard clear messages that indeed progress is being made, but more needs to be done to close the gaps, sustain financing, and ensure that AMR remains a shared priority. To close today's session, and to leave us with a forward-looking message that will guide our actions during this World AMR Awareness Week and beyond. It's my great honour to invite Mr. Luis Vinales Torres, Director of Health Systems Division, WHO Regional Office for the Western Pacific, to deliver his closing remarks. Over to you, Luis. Thank you.
Thank you, Geraldine, and good morning and afternoon, everyone. Again, we are going to close this fantastic 90 minutes webinar put together by the team. I hope that you have enjoyed it, the same that I did. Let me add a few points and reflections. First of all, happy WAAW, because that's how it's called. The World AMR Awareness Week. So what a nice name. So thank you and happy WAAW to everyone. The second point is I want to congratulate all countries for the reporting on TrACSS. I want to recall here there was our colleague from Singapore, Professor on Tech, that was saying this is more a process indicator tool. It's important. And it's good that we have improved the compliance and the availability of data on progress, but it's part of a bigger picture that we should try to work all together. Now let me share a few reflections. Let me start for the good news first. I think the good news to share, or the ones that I'm taking definitely, is we have improved on awareness. I think that and particularly last year with 30 countries supporting in the UN, in the UNGA, the joint declaration Asia Pacific on more action for AMR. We have improved and awareness is there, and we know and we are spreading the word that AMR it's a big issue. We have improved in reporting, and today's presentation is proof on that, and we have improved in planning. But and within the good news, and we have even improved in action. And I want to quote here our colleague from Indonesia, where a very concrete action that for me shows the way of improving implementation. For example, including AMR as part of the accreditation process for the health insurance to make sure that facilities have to introduce the processes to improve AMR stewardship and AMR monitoring and action as part of their accrediting process. This is just one example of a good practice. Still, though, there is plenty of things remaining, and we all want to move the needle. And to move the needle, let's say, on the second part of the theory of change, on the outcome, on how we are going to reduce the use and improve the wise use of antimicrobials. There was a call for antimicrobial monitoring use. No, it's good. We are improving the availability. Better data is there, but still there is a lot of challenge on the utilization of this data. The fourth point in my second reflection is just to share with you, if you are not aware, antimicrobial resistance team head by Nishi and with the coordinator Geraldine is sitting in health systems in the Western Pacific Regional Office. That's not the case in other regional offices, or there is only one more. But the importance of this location in our organigram is AMR is a systematic issue. It requires to look at the engine of the systems to address it. It requires to look at health workforce, at behavior of prescription. It requires to look at communities. It requires to look at financing, at the supply chains, at the availability of drugs and the regulation. So it looks at multiple areas, and that's why it is in the health systems, and we really want to convey this message. The other message that's still there is, and it was mentioned, I believe, for the Philippines colleague, is normally we see a lot of progress in tertiary hospitals where there is a lot of resources, where there is a capacity, where there is better data, but probably we need to bring the battle to primary healthcare. Is there? Is it the front line? Is it the ability? Is the availability and use at community pharmacies that we also need to make a difference to move the needle? So that's a very strong message that it came from me out of this webinar. My fifth point is the role of everyone, and I think it was clear. And I think when we look at the stakeholders that we are monitoring and TrACSS, it's also very clear. Everybody has a role here, and we need to kind of continue spreading the word to make this effort. And final, I really want that invite all of you to be part of this army of AMR that we are all forming, and try to adhere to our WIPRO AMR pledge of one region, one commitment, and boost all our efforts to make this happen. Thank you for being with us today, this morning, this afternoon, and looking forward to continue working on the AMR challenge. Over to you, Nishi.
Me. Thank you, Luis, and thank you again to Dr. Kadong Park for joining us for this webinar, and to all participants, speakers, and colleagues. A recording of this webinar and key takeaways will be shared through the WIPRO AMR network and WHO's regional channels. We encourage you to continue the conversation and share your reflections on how your country is TrACSSing the path to action. With that, this session is officially closed, and have a meaningful World AMR Awareness Week. Thank you.
Thank you, Geraldine.
Thank you.
We have to
Oh, yes.
Sorry, Geraldine, I thought that you were the one.
No, it's fine. It would make sense.